Welcome to part 2 of our highlights from the recent Shanghai GU Oncology Highlights meeting, featuring a mixture of international and national guests. Coming up in this episode, you'll be hearing from Steve Freedland talking about the management of high-risk biochemical recurrence. Dr. Liang Liang overviews advanced prostate diagnostics in northern China. Andrea Necchi from Milano will be talking about neoadjuvant approaches to high-risk muscle-invasive bladder cancer. Dr. Xiaojie Bian from Fudan University Shanghai Cancer Center on high-tech drug development within China. Thanks again to our conference highlights partners, Bayer China. Another international guest joining us, Yao Zhu. This guy's an old friend of this Shanghai meeting.
Steve is always a welcome guest.
Yeah,
Shanghai.
It's great to be back.
Professor Steve Freedland, urologist at Cedars-Sinai in California. Yeah, I've been here with you on more than one occasion.
Multiple times, yes.
Yeah, so we could pick your brain about anything with prostate cancer, but the really big thing that you've published over the last year or two in a few subsequent publications is the EMBARK trial, of course, New England Journal of Medicine publication last year. Look, it's really important, I think, especially for urologists, but also radiation oncologists, to get our heads around what this means for this so-called high-risk BCR population. So could you first of all just briefly summarize it to us, if you don't mind, Steve, what EMBARK was all about, and then we can talk about, the impact out here in China and Asia-Pacific region.
Yeah, no, absolutely, and happy to do it. And I think what's exciting about EMBARK and any trial is you think about what does it say for that disease space, but then what does it say for the field in general, try to broaden what you found. So specifically, we took patients that were high-risk biochemical recurrence, conventional imaging negative. CIN, conventional imaging negative, hormone-sensitive prostate cancer, doubling times less than 9 months based upon the old Hopkins data. PSA had to be high enough post-surgery, post-radiation, couldn't be candidates for salvage therapy. So this is really, one of the key questions that we still have is when to start systemic therapy. EMBARK doesn't answer that. It answers the how. So this is when you are ready to start, how should I do it? Okay. And so patients are randomized to enzalutamide plus ADT, ADT alone, which would be your standard trial that we do. And for the first time ever in a phase 3, enzalutamide alone. So you have that third arm, which is really interesting. The other interesting aspect was compared to modern treatments where it's more and more and more and more, we also included de-intensification. So after 9 months, if your PSA responded well, you went off therapy. And then we would wait for the PSA to go back up, which it did in most people, but some it didn't. And then you'd go back on your original assigned therapy. So that was the basic design.
And MFS was the primary endpoint. You were trying to see control. We could describe Eligard as the ADT as the control arm, I suppose.
Correct. So ADT was our control arm. Yeah. It's MFS, which I've learned most people don't understand that concept. MFS. We talk about MFS and everything. So when I give talks, it's metastasis or death. Put it in words that people can actually understand. And the idea is we want to keep our patients in this good space, alive with no metastasis. That's where you want to live, right? Yeah. You don't want to be dead, and you don't want to have metastasis. They're both bad things, so we're trying to prevent bad things from happening, alive without metastasis.
And it was very positive, hence it's New England Journal. So what did you show in summary, and your intriguing point about it's not just combining, it's not just adding ENZA to ADT, it's what about ENZA on its own. So tell us about those two arms in particular.
Yeah, no, absolutely. So if we look at the risk of metastasis or death, by adding ENZA to ADT, you reduce that risk by 58%. It's really, really impressive. Curves separate early, keep getting further and further, and the suggestion of OS benefit, p-value of 0.01, still early, didn't reach the pre-specified threshold. But when you look at the ENZA alone, 37% reduction in the risk of metastasis or death. So not quite what we saw with combo, but patients routinely don't always select the most effective because there are other factors that drive decision-making. And in particular, with the monotherapy, you see much better preserved sexual function. I'm sure there are other factors in talking to people, We didn't see that as much in the trial. I think it's a limitation of the questionnaires we used, quality of life benefits, but certainly much better preserved sexual activity, which is important for a lot of our patients, for sure.
Sure is, yeah. So, because we all have these patients, they're well. It's just the PSA is going up, and it's going up quickly. So they've had surgery and or radiotherapy. The point is they're not suitable for more salvage therapy to the pelvis, and ADT is your next stop. But, especially in these younger men, it can really impact quality of life. Well, what's your reaction to Embark?
Yes, so the Embark is really a practice-changing trial, and it's fit right in the space, patients with high-risk BCR. And in old days, we do not have very effective to prevent the metastasis-free survival, which is clinically meaningful. But Declan, I'm a big fan of PSMA.
Yes.
So we have a lot of PSMA scan in China, and now it's really suitable for patients with BCR. And we see some patients may have like multiple metastases in the PSMA scan, but really normal conventional imaging. So what's your recommendation to this kind of patient? How do you translate the impact data to their treatment?
Yeah, no, it's a great question. There's actually a very nice study coming out of UCLA where they looked at Embark-like patients that would have qualified for Embark but had a PSMA scan done. 86% had something positive on the PSMA. 45% of the time was metastatic. So 40% was some local, regional, but still 14%, 15% or so negative. So I think I've heard this, well, we'll just wait until the PSMA scan is positive. It's not going to happen. Because we look even in the MCRPC data, late stage, 15% are PSMA negative. So it's just a subset of tumors that aren't going to make enough PSMA to be seen on a scan. You can't wait. But so the question is, if you have some lesions, you're conventional imaging negative, you have a positive PSMA. So first off, are you metastatic? Are you not? It depends on, you're metastatic, but do the traditional MCSPC trials that we have the data on wouldn't have enrolled that patient because they're conventional imaging negative. Embark would have. So we have data from Embark that patient benefits from more aggressive hormonal therapy. We think that patient benefits from metastasis-directed therapy. So we can either do what we know works, what we think works, or both. Those are your options. And, the more I think about it, the more I'm like, I don't want to give up what I know works for something that I think may work. The ideal to me is, if possible, is combine them. And again, that's where the beauty of Embark is. It's not lifelong therapy, right? Because that's one of the points of metastasis-directed therapy. Maybe we can cure some of these guys, buy some time. With Embark, it's 9 months.
Then stop if the
stop
PSA is
it.
below 0.2. That's
Correct. And then hopefully we can get even longer off treatment, and maybe we can start to cure some of these patients.
Yeah. And finally, just about the enzalutamide monotherapy, because as you said, that's a unique thing about this, and the idea of not doing ADT, enza monotherapy, but just about some of those predictable side effects of being on an AR pathway inhibitor on its own, impact on breasts and so on.
Correct.
What's just your pragmatic way of approaching those patients? Because I'm sure this is the way we're going to be managing our high-risk BCRs once we get access to this, like a lot of monotherapy.
No, absolutely. And so I think that's the one big thing is, that because they're not castrate, they actually get feedback inhibition from the enza. Their testosterone actually go up. It gets aromatized to estrogen. You're not blocking AR, so you have really high unopposed estrogen. So it's going to lead to breast growth, 45% enlarged breasts, 15% nipple pain. So we think prophylactic radiation to the breast, 1-2 doses before. Certainly in the bicalutamide days, it works. We don't know that it works for enza, but it makes sense that it should. Tamoxifen has certainly been shown. And again, anecdotally, I'm talking to people that these are working. Anastrozole is a aromatase inhibitor, not quite as effective anecdotally. And then if all of that fails, there are outpatient surgeries to remove the breast tissue. But the one point I would make with all that is it needs to be done prophylactically. You can't wait and give the drug, wait for them to get the breast enlargement and the breast pain, and then treat. It needs to be done beforehand.
Yeah. There you go. We'll all be getting used to that as we get access to this. But congratulations again. A big practice-changing study. And We haven't yet embraced it in our paradigm in Australia, mostly for reimbursement reasons, but it's really, really valuable work. And congrats to you and all the team for leading.
No, thank you. It was a huge team effort, and obviously Neil Shore was very involved. Yeah. Many people, Astellas, Pfizer, global study, all the patients. So it takes a village to make these kind of things happen.
So I'm joined now by another expert guest from here in China, Professor Liang Liang. Thank you for joining us, Professor Liang. And you're from the northwestern region of China. Please tell us a bit about where you are, where you come from.
Thank you for having me. My name is Liang Liang from northwest of China. And northwest China is a developed area in China, but it contains 1/4 area of China. It has a lot of big areas, and a lot of people. But for the prostate cancer, this is a virgin area. None of the PCA screening projects can be found there.
Yep.
We are one of the toppest hospital in the northwest of China, and since 2022 to 2023, we performed the first Northwest PCA screening project.
Because of course, like many countries, China doesn't have like a national official screening program. Yeah. We actually spoke to another colleague before, Professor Peng Wu, down in the far side of China, the southern area of China, and we talked about this. And I understand a lot of men have very advanced disease as a result. But you have developed an interest in early diagnosis and screening, and in precision approaches. So tell us a bit about your approach to the early detection and screening.
In northwest China, actually, we are in the middle of China, and our city is called Xi'an, which is the terracotta warriors located in our city.
That's right.
That's right.
Beautiful.
And we have 13 million patients. Actually, we have 500,000 males, more than 65 years old. We contact with the communities, and which is similar as previously Professor said. And during these 2 and 3 years, 500,000 patients was screened, and at least 10% of these patients have the higher PSA level.
Wow.
And 1% of the screened patients is prostate cancer patient.
Can I ask you, of these 500,000, so what's the age at which you start inviting them to come to be screened?
At least 60.
60, not 50?
No,
yeah,
50.
So a little bit older.
Because in our community area, there is another screening project. The limitation for these males is 60 or 65.
Okay, very good. And how does it work? Professor Peng had told us they are collaborating with a community health, primary health team, which is the key, of course. You're the specialist, but do you have a collaboration with the primary health care or community health care?
Yes, we have the similar organization, and we collect the different community clinic and the high school clinic, at least 35 or 40 in our in our cities. Yeah. All these guys we can collect the serum.
Great. Yeah.
Now we get a serum, and we finish the detection. Then we return the result to our clinic. Then we will get a message, or you get bad PSA level. You have to come to
your clinic.
Yeah.
So very interesting. So the PSA is still the first step, and you're inviting them and you're collecting the data. But I know you do have an interest in more sophisticated precision approaches for these men. So please tell us a little bit about that. I suppose we're talking about the men who have had a PSA that's a bit high, and so they do need to come and see you. So please tell us.
We mainly focus on the PSA, prostate cancer early detection, and the urologist intervention, biopsy, and focus therapy. For in our area, we mainly focus how to find the prostate cancer patients as early as we can. So for the biopsy, before the biopsy, about 3 years ago, less than 50% of the patients not perform the MPMRI in our hospital, even in the northwest of China. During these years, with the development of the urologist and with the development of the meetings, all the patients and all urologists know the MPMRI and the BPMRI is very important for this patient. And 3 years ago, it's less than 50%. At this moment, the percentage is much than 80 to 90%.
Wow.
That's a
are getting an
progress.
MRI.
Yeah.
And I think it's so important to think about that because in the US, for example, I think the proportion is maybe 30% or 35% across the whole region. So this is really impressive. And you mentioned biparametric as well. So what's your thoughts on biparametric versus multiparametric? So I suppose we're talking about the contrast or not. Yeah.
I think there is no significant difference because in our hospital, for the BPMI or the MPMI, and the patient have to wait less than 2 days to perform the scanning.
2 days later.
Less than 2 days.
Oh my goodness me. I'm very envious, most would be. So this is a very advanced practice in northwest China. As you say, it's a developed part of China. But this is like world-class early detection program. So my question is, does it make a difference? Are you seeing patients more and more with early disease rather than more advanced disease?
Right. We have these opinions. Because in our center, we have performed 1,400 biopsies 1 year.
Yeah, in a year.
2 years ago, 30% or even 20% of these patients with a higher PSA level, more than 500 picogram per milliliter.
Yeah.
Recently, seldom these patients or seldom these candidates is more than 1,000.
Yeah. And this is also remembering that you're starting at 60 or 65. So we will expect that a few patients in their 50s might have missed the boat, but that's still very, very impressive, I must say.
Yeah.
And look, I think my take-home message from chatting to yourself and Chinese colleagues here at this conference in Shanghai today is while there's still variability in the access to early detection, I'm incredibly impressed with the institutions or the regions that have put in place an early detection program. These patients seem to be getting access to world-class diagnostics in a timely fashion and getting access to great expertise like yourself in your institution, Professor Liang.
Thank you. And at the same time, we perform the Lucium PSMA PET-CT scanning before the biopsy, but not all of the people.
Before the biopsy even? Yeah.
Not all the people. For some prospective trials, these guys can got this PSMA scanning.
On trial,
but most of the people, before they performing the robotic assistant laparoscopic, we will perform this scanning in our hospital. In our hospital, we perform the PSMA 177, more than 2,000 cases. I think that's
for MCRPC, I presume.
MCRPC.
So this is a very advanced prostate cancer service, I must say.
That's why we are one of the biggest prostate cancer research center. But it's very interesting. In northwest of China, we have the lower morbidity of the prostate cancer compared with East China, even compared with the south part of China. Because in our area, in our hospital, we don't have any other screening tools except PSA. That's it's a pity for us. We try to collect the data from the prostate health index, and in this year, we try to talk with our different parts of our hospital, try to get it available for us to perform the PSI or 4K examinations. And at this moment, we collect with other colleagues and the universities. We try to collect the different the urine or the serum to get our localized markers in the serum and urine to get our Chinese-based database to find, because you know that the PSA threshold and the prostate health index threshold is based on Western-based database, not from Chinese.
Not from Chinese and Asian men.
The 4 nanogram per milliliter. I'm not sure whether it's available for China or not. I think our government or our urologists maybe we can make a multi-center analysis to establish the new standard, the new threshold for our Chinese people.
Well, I remember when I first started visiting China 10 years ago, we were not having these types of conversations. We were talking about just widespread men presenting with very advanced disease. So it's great to hear from you, Professor Liang, and thank you very much for sharing all that progress with us.
Thank you. Thank you for having me. Thank you.
So we're now joined by another of the international guests, Professor Andrea Necchi, GU medical oncologist from San Raffaele in Milano. Welcome, Andrea.
Thank you, Declan. It's a pleasure to be here. Thank you.
Yeah, you've been to China before, I think?
Actually, the second time. Yeah, I've been here for the Shanghai meeting in 2019, so before the COVID period. Yeah.
Glad to have you.
Yeah, thank you.
So it's great. So you're obviously a very big urothelial cancer expert, and you gave a fascinating talk this morning over the landscape of immuno-oncology in muscle-invasive bladder cancer. So I think it's one of the most exciting areas in GU Oncology is the immuno-oncology agents coming into the perioperative kind of neoadjuvant, adjuvant, and Andrea today presented a talk overviewing all of that. But what we wanted to talk to you about today is a trial you've been involved with, the NUR, a combo trial published in the JCO just a couple of months ago. So can you tell us a little bit about that? Because that's a very fascinating trial.
Thank you. The NUR combo actually followed the pursuit of identification of novel combination therapies, active combination therapies, preoperatively and perioperatively, including a neoadjuvant period and the adjuvant postoperative period, trying to overcome the limitation of chemotherapy. And in particular, address the patients who are unsuited for cisplatin-based chemotherapy or who refuse cisplatin-based chemotherapy, which is a consistent patient population worldwide. We started in 2017 with Pure-01 with immune therapy alone. And then an explosion of clinical trials happened since that time. We started the combination therapies, including chemotherapy. Well, still in the concern regarding the use of chemotherapy in patients who are refusing chemotherapy, actually, but trying to shift our focus beyond cisplatin or platinum chemotherapy. There is a plethora of potential chemotherapeutic agents to combine with immune therapy. We started combining Abraxane, so the albumin-bound paclitaxel that is used today for pancreatic cancer and other solid tumors, combining Abraxane with Pembro in second, third-line therapy in urothelial cancer, and we published in Annals of Oncology in 2020, 40% response rate. And since then, we tried to invest on an earlier disease setting with a pretty similar combination with nivolumab and paclitaxel in the perioperative setting, 4 cycles of combination therapy before cystectomy, and then a tail of adjuvant immune therapy with nivolumab alone for 1 year. So the response rate, which was a primary endpoint for the study, relatively small study, a single-arm study of 32 patients, was above 45%. So really promising. And there is, of course, a lot of translational research, which is part of which is already ongoing, that is focusing on the potential synergies between the drug and trying to explain and dissect the contribution of the two drugs and explain the mechanism for the combination therapy. And there is a rationale for combining taxane with immune therapy. So let's see if we will identify a bit more by digging a bit more on the biology of the tumors pre and post therapy. The neoadjuvant setting is pretty much well suited for this kind of approach because it allows you to have pre and post therapy biopsies, to invest on biomarker research, and also to allow young fellows also to build a career on this path.
Fantastic, because there was a young fellow who presented this, I recall.
Yeah, first name, Chiara Marcinelli, rising star in GU Oncology. We desperately need rising star in GU Oncology, you know, in European Union. So our aim as a university professor, you know, is to educate people and to provide these people, young guys, with the possibility to have the career.
Yeah, and you come from San Raffaele. We know the urology department there very well, as you, don't we? And one of my current fellows, Elio Mazzoni, is a protege of Briganti and Montorsi and all those. So it's an interesting population. So these are patients who were cisplatin ineligible or they declined it. So it's the first question we would have as urologists is, well, how are they going to go with more chemotherapy with paclitaxel plus immunotherapy on top of it? What do you think before we hear about the toxicity?
I mean, Professor Andrew just mentioned the response is really high. More than 50% of patients get very nice response of this regimen. And my question is that if we can get such a high response, whether this kind of treatment can be called like perioperative, whether we need to remove the blood or we are trying to keep the blood intact and trying to
question, doesn't it?
Make another new endpoint to define the good outcome.
That would mean changing, providing a big change, you know, and maybe changing the practice, really having a deep impact on the patient quality of life and potential for cure, as compared to the classical neoadjuvant studies, like a Niagara study also. That for sure, providing survival is a primary goal, but today providing improvement in survival while keeping the bladder is the next goal. In order to do so, we should be pretty well positioned in terms of pathological responses that we are providing within these trials. I'm still a bit skeptical about the possibility, as it currently stands, as with the regimens that have been used today, provided results today, that we are already well positioned to provide the patient with this opportunity, because as I mentioned in my talk, we should have at least a 50% path CR rate with any kind of regimen to say, okay, this regimen or this drug is pretty well positioned to keep the bladder intact for the patient. We have not still seen any results of this kind, at least in ITT population from many trials. In the Sunrise 4 study testing intravesical therapy, TAR-200 immune therapy, in the population of patients with the less extensive disease, clinical T2 stage, we hit this bar with the 50%, meaning that we should be braver and we should be smarter in selecting patients maybe, and in the near future maybe based on biomarkers, in order to achieve this goal and to provide the patient with this kind of path while saving the bladder.
Yeah. Another point is that in China we have a high incidence of abstract urinary cancer. Nearly in our department, nearly 1/4 of the urothelial cancer patients, they have abstract urinary disease, and we know it's very tough disease to treat, and the need to keep the bladder in kind of kidney intact is also a unmet clinical need in these patients. So how can you comment on this kind of disease?
Well, you know that Chinese people and the urothelial cancer of the upper tract originating from your region is particularly rich in HRAS and then RAS mutation. When it comes to the urothelial cancer as compared to the renal pelvis cancer, there is a differential genomic biomarker landscape. So maybe that in the future, targeted therapy addressed to novel targets in this space will provide this patient with this opportunity. Immune therapy is not sufficiently shaped and positioned to get an impact on these tumors, because these tumors are more frequently cold tumors, immune excluded. So immune therapy, at least as single agent therapy, is not a good job. Let's see if with the ADC and immune therapy we could shift a little bit the paradigm. Yeah. But for sure the upper tract is another focus in which providing an organ-sparing approach is very, very important.
Yeah. Fantastic. It's been a great few years in urothelial cancer, hasn't it? And from this very advanced disease to now we're right into this perioperative for very nasty cancer. So congratulations on Neurocombo and all the great work coming out of San Raffaele and your group. Thank you for joining us, Andrea.
Thank you. It's always a pleasure to collaborate with you and to participate in this meeting. Thank you.
So here on GUcast, especially on our China-themed episodes, we've talked a lot about these new wave of Chinese robots, surgical robots that have been coming out of here, especially through 2024 and onwards. And that excites people like me, a urologist. We like playing with these toys and so on. But what we haven't spoken much about is the oncology industry, the drug industry here in China, because what we see now is lots of high-tech drugs, new drugs coming out of China. So it's a great privilege to welcome Dr. Xiaojie Bian to talk to us on GUcast about this episode. Xiaojie, thank you for joining us. Can you please introduce yourself and tell us where you come from?
Thank you, Murphy. I'm Xiaojie Bian from Fudan University Shanghai Cancer Center. I'm a urological oncologist, and now I'm mainly working on the clinical trials and some new drugs like that.
Fantastic. And we know your institution very well, Fudan University Shanghai Cancer Center. My cancer center, Peter MacCallum Cancer Center in Melbourne, has a long-standing institutional agreement that myself and Professor Ye Dingwei started 8 or 9 years ago, and I've been to visit your center many times. It's amazing. So yes, I know you do a lot of clinical trials, but what I really want to pick your brains about is some of the drugs that have been developed in China in GU Oncology that I know you have some interest in. So yeah, tell us about some of these new drugs and the disease areas they're in.
In the past, the drugs are mainly on the AR receptor pathway, and now we have some new drugs or new targets about something like TROP2 or EGFR or PISMA, just like that. You know, that lutetium PISMA 617, everyone knows that. Yeah. And we got a very wonderful clinical trials results, and now we can use these drugs for the patients. But for the drugs, just like the ADC, antibody conjugated drug and conjugated or project, these drugs are very new or very novel for us, not only for the patients but for the physician. And now in China, we are focusing on some targets just like EGFR, TROP2, PISMA, or B7H3, these kinds of ADC. And these ADC drugs with these targets and with the payload of MMA or just like a TOP1 inhibitor. And those drugs are, at present, we get a little bit of promising results, and we hope that these results could take new hope for the patients.
So that's amazing. You've just given a list of an incredible array of high-tech oncology drugs, everything from AR pathway inhibitors, and we've seen that trial already be published and read out from here in China, right up to ADCs. These are really complex drugs. So can you tell us a bit about, in your cancer centre, I've been there, there's a huge bench-to-bedside program. You have lots of scientists and tissue, big clinical trials unit, huge patient population. So tell us a little bit about how you take these drugs from in the laboratory through to clinical trials.
We did some bench work of these patients for the prostate cancer, and we do the immunohistochemistry and to evaluate the expression of these targets, and we found that the expression of these targets are very high in the prostate cancer cells, much higher than that in normal cells, so these targets are promising. And we also do some clinical trials, stage 1, stage 2, we already come to the stage 2, and for small sample trials, we got the promising results, and we found that not only the PSA response rate, but also the radiographic progression-free survival prolonged, and we got a very promising result, and we hope these clinical trials can come to the stage 3 clinical, and more patients could benefit from these drugs.
And one of the big things about China, of course, is the scale of everything. And that's what I see every time I come here. You can take something from phase 1 to phase 2, and then if readouts, you can recruit 500, 800 patients over a couple of years. So it's one of the advantages of the scale, but still it's a challenge. The logistics in running clinical trials is very challenging. So you have a good infrastructure in Fudan University for running big trials, I think.
Yeah, the speed of the enrollment is very fast in our center, not only in our center, but also in the mainland of China, because the population of the patient is the number is very large.
Yeah. Now you mentioned ADCs, antibody drug conjugates, very exciting area in oncology, but it's a very high tech area. Mm-hmm. Tell us a little bit about your interest in developing ADCs in GU Oncology.
These targets I have mentioned above, including EGFR and HER3 and B7H3 and TROP2, also Nectin-4. We also did some exploration in prostate cancer. And besides that, not only ADC, but also RDC, radio drug conjugate.
I've learned a new term today. Thank you.
These drugs are just like the PISMA lutetium 1777. This drug is also one kind of the RDC, and we can change the nuclear, not only the lutetium, but also to 225. We can change. And in this year's ASCO, I think that another phase 1 clinical trial had showed the promising result, and we can get a lot from that kind of clinical trial, and we can try that in mainland of China in our prostate cancer patients, and we hope we could also get the promising result.
So there you go. It's not just all the Chinese robots that are coming out that we're very excited about. We also need to turn our attention to the oncology drug development industry here in China. And we're very grateful to you, Dr. Bian, for coming on and telling us about this. And I wish you all the best with your lab. So again, one of my favorite topics over the past year has been talking to Chinese friends about these new waves of surgical robots coming out of China. Just amazing. We can't get enough of it. And I'm really pleased to be joined by someone who knows a bit about this. This is Dr Hongkai Wang, urologist here in Shanghai. And we're here in Shanghai today at Fudan University Shanghai Cancer Center. Thank you for joining us.
Yes, nice to meet you, Dr. Declan Murphy.
Yeah.
And nice to meet you, my friends and our friends on the internet, maybe from GeoCast. Hi. Today, I'm very honored to come here to talk about robotic surgery and robots in China.
Yeah, because of course you have experience in your center in recent years of Da Vinci surgery, but we know all about that. We want to know about the new robots.
Before I talk about the new robots, I think you will be interested in some of the data of the robot surgeries in China. And actually, you know, from the past 10 years, the whole country have did about 580,000 robot surgeries. Among them, 50% are for urology surgeries.
And these are all Da Vinci surgeries you're talking about?
Yes, most of them Da Vinci surgeries. But, we have more than 3,500 tertiary hospitals in China. But now we have only about 400 sets of robots. So we know that...
Let me just say that again.
Yeah.
So there's about 3,500 tertiary hospitals, so very specialized, but only about 400 of them have surgical robots. So, wow, that's a lot of big hospitals without robots.
Yes, maybe only 300 because some of the hospitals have 2 or 3 robots. There's another data from Shanghai, and we are doing lots of robotic surgeries for urology now in Shanghai. And actually, we have only 35 sets of robots in Shanghai now.
Okay.
This is a big city with about 30
million people.
Yeah. And only 65% RP are done by robots.
Okay.
30 NSS are done by robots, and 50% radical cystectomy are done by robots. So if we look into the data for radical prostatectomy, the penetrance rate of robots is not so high, I think, only 65%, because we don't have so much robots now. And that's why we're talking about new robots today in China, because we're trying to work on new domestic robots so that we can have more robots to use now.
So we're already familiar with some of them, not personally. We don't have these robots in Australia, but the Edge Medical robot, the Medbot Toomey robot, the Shuri robot, and so on. And I've heard about another one here at the meeting in Shanghai. So tell us about your own experience in your center, because you've been evaluating some of these.
Yeah, we're working on a modulated robot, which means it has separated arms.
Separate arms,
Separate arms, just like Hugo. Yeah. This robot, they're trying to make it better, and they're trying to solve the problems of robot systems, because, for example, maybe it's too expensive, and maybe it's too big.
Yeah.
So this robot we're trying on is called Karina. And I think it has some advantages. They're trying to make it smaller, so our nurse can easily push it to the right place.
Yeah.
And they are trying to make it more lower cost.
Yeah.
Actually, there's also some other advantages, and but maybe the performance of those robots are all excellent enough for doing surgeries now.
So tell us about the Karina robot. You've been using it in clinical situations?
Yes.
Urology just?
Right. We have done its phase 1, phase 2 clinical trials, and upon now we have did more than 32 radical prostatectomies using Karina.
Yeah.
And actually the data, the surgery time, the consult time is quite the same as Da Vinci.
Okay.
And we can see the data from our article, which will be published soon. We can see the data. Yeah.
Oh, so this will be the first initial experience of the Carina robot. And
Yes.
yeah, yet another fantastic robot coming out of China. And have you any other robots on the radar to be trying in your institution?
Actually, we are trying to have Shuray,
Yeah.
maybe. And maybe we are also very interested in Wei Chuang and Jingfeng robots.
Yeah.
We would like to try. Yeah.
Amazing. So there are 8 or 10, I think, as we speak here at the end of 2024, already in play and more in development. So
Yes.
it's just the start of a wave, yeah.
Yeah.
But look, it's very exciting, and we wish you all the best with the program, and we're looking forward to seeing your article come on the Carina robot. And thanks
Right.
very much for joining us, Dr. Hongkai.
Thank you. Thank you.
Take care. So there you go. We packed in as much as we could in these 2 podcasts, try and get a flavour of this amazing meeting here at GU. But yeah, it's been great. Good fun talking to our guests.
Yes, it's great to talk with these guests and to share the information, and it's great to have the GUcast in mainland China. We have a lot of followers and fans in the WeChat and in some of the Chinese social media, but it's great to have you here and to have face-to-face GUcast. So the amazing GUcast.
I have to say that's been the highlight of coming here, is meeting all these great Chinese colleagues who've been listening to GUcast. Great suggestions, they've enjoyed the content. And thanks very much again to our friends at Bayer China who enable us to be here and produce these themed episodes with your help as our China editor and to support our conference highlights. And we'll be back again very soon.